Welcome today to the Underserved Population Network call. We want to thank you for taking your time out today. I'm Misty Kevich, and I'm one of the nursing coordinators at WVMI with HHQI. We're very pleased to have you today on our call. We have two excellent presentation and speakers today from Qualiance, which is the QIO of Connecticut. So I'd like to introduce first Kathy Roby. She's a consulting director for home health care at Qualiance. She specializes in teaching and educating nurses, focusing on improving home health provider clinical outcomes and reducing acute care hospitalizations for Connecticut home care providers. To achieve these goals, she conducts on-site audits of home health agencies, analyzes workflow processes, and makes recommendations for efficient processes, resulting in better outcomes for patients. She also functions as the quality manager for home health care providers with limited staff, reviewing records, recording information, and completing required state and federal quality audits. Ms. Roby has also spearheaded the development of Qualiance, a first-of-its-kind software that enables home health agencies to automate their audit and reporting requirements in a convenient online format. And we're going to get to see a demonstration of that today. In addition, Catherine is an adjunct clinical instructor at the University of St. Joseph School of Nursing, teaching community health nursing. She is also a frequent guest lecturer at their home health educational events. She holds a Master's in Science of Healthcare Administration from the Hartford Graduate Center, an MED from the St. Joseph College, and a BSN from the University of Connecticut. She is a certified home and hospice care executive through the National Association for Home Care and a certified trainer for the Integrated Chronic Care Management. Additionally is Rita Grimes, and she will be our first speaker today, and she is a consultant for home health care at Qualiance. She serves as the lead for several home health consulting contracts and is an educator and trainer, as well as a key resource for home health administration and staff in data analysis, abstraction, integrating chronic care training, and quality improvement. Rita has over 30 years of professional nursing experiences and has served as a field clinician, supervisor, educator, and consultant. Prior to joining Qualiance, Rita worked for the Visiting Nurses and Health Services of Connecticut and was the Vice President of Performance and Quality Improvement for 6 years. During her tenure at the VNA, Rita has led agency quality improvement teams who resulted in reduced hospitalization rates to below state and national measures. She managed the implementation of best practices for wound care, med management, pain, and depression screening in the agency, as well as directed and led the Health Information Management Department to ensure record accuracy, access, and confidentiality. Rita also coordinates and leads educational presentations on OASIS and depression screening interventions at the Connecticut Association for Home Care. She holds an MSN from the University of Hartford and earned her BSN at the University of Victoria in Victoria, Canada. She is a licensed RN and certified in diagnosis, coding, OASIS, chronic care management, as well as a CHAP consultant. With that, I'd like to turn the presentation over to Kathy Roby. And I apologize, we actually are turning it over to Rita Grimes first. So Rita, go right ahead.
Thank you, Misty, for that introduction. I'm so pleased that you've joined us today to talk about how to manage by data. We are finding agencies are losing agency-level knowledge related to quality improvement and to reporting, as work functions are consolidated in response to the many numerous changes in the industry. And certainly we have many challenges coming down the pike this year as well. So today we're going to review for you how to identify key reports needed in your day-to-day operations. We'll help you identify key data points, to identify where to focus your QI efforts, and Kathy will review for you an internet-based tool for assessing survey readiness. Our objective today is to turn data into practical information that can be used across your agency. Specifically, how to use your OASIS CASPER reports to direct other essential agency functions that you see listed on your slide here. At the top right side of the model is your compliance program. In regard to compliance, OASIS-C is a standardized data set required by CMS. We're required to collect the data and to go further with it. We're required to use the data to then improve the care we provide. OASIS data and reports can help you identify whether you're in compliance with submission of reliable data, for example. In regard to organizational culture, it's truly critical to understand OASIS reports and to be able to put those reports into context for staff throughout the agency. In essence, OASIS tells us a story about our patients, our patient population, and outcomes of care. It's critical that you be able to tell a story about your patients, engage patients and people, and we know that stories certainly do that, and that will allow you to engage people in quality improvement programming. Ultimately, of course, the intent of managing by data is to do what the Office of Management and Budget and the National Quality Forum mandated all providers to do, and that is to provide safe, timely, effective, efficient, equitable, and person-centered care. If you know how to look at your CASPER reports, this will help you inform your practice and drive your performance improvement efforts. So whether you practice in acute or subacute settings, the process for quality improvement always involves 9 steps represented in the cycle on your slides right now. The cycle begins with OASIS data collection, but at the center of those 9 steps are your OBQI, PBQI, OBQM reports that you download from your CASPER site. So that's the outcome-based quality improvement reports, the process-based quality improvement reports, and the outcome-based quality management reports. And these are essential to inform you throughout the improvement cycle. The reports show us how to measure patient outcomes, target reports for improvement, implement an action plan, monitor those results, and begin again by collecting OASIS data, analyzing your reports, and so it goes until you've achieved what your intent was to begin with. So, managing by data should ultimately inform your practice and care processes. This is really the overall global rationale to looking at reports. It should help you to predict patient outcomes as well. The thought being, if you can predict the likelihood of the results of care, you can prevent undesirable outcomes. CASPER reports contribute objective data rather than experiential knowledge alone. In my experience, there are 5 essential reports that you'll want to download, and they're listed here on your slide. When you're looking to improve specific outcomes as well, there is the Agency Patient-Related Characteristics Analysis Report. This will help you to drill down to identify specific characteristics of patients who achieved an outcome rather than characteristics of patients who did not achieve that outcome. Though not essential, it is desirable to look at that report. So for those of you who are new to the QI role, or for those who have just put on yet another hat at your agency, and this is fairly new to you, let's go through the steps to accessing your CASPER reports. You will need, to begin with, access to two sites. The first site is your CMS Secure Access Services System. This allows you into a secured government site. And the second is the QIES National System, where your CASPER reports can be found. CMS requires that you have an individual logon and passcode, and you can apply for access at the QTSO site. That's the Quality Improvement and Evaluation System Technical Support Group site. So once you have both passwords, you will log on to the QTSO website, then select the CMSNet Submission Access. You will be asked to then select from this location your state from a drop-down menu. Once you've selected your state, you will need to click the Select button or the Go button. Just a reminder here that some sites may look marginally different dependent on your location. In order to enter the secure government site, you'll need to adhere to all regulations, policies, and protect the potentially sensitive information from your downloaded, that you're downloading or being viewed. So select Proceed, or you may have a Go button to continue. This is where you'll enter the first of your two passcodes, and this will allow you access to the secured government site. You'll then come to this screen, and this is the QIES National System Logon, where your second passcode resides. This will allow you to actually get to your CASPER system reports. And you've arrived. You'll see many different messages on here, many updates from CMS itself. You will want to, as indicated by the red arrow, select CASPER reporting, and CASPER reporting stands for the Certification and Survey Provider Enhanced Report System. So select that button, and you'll come to the Welcome screen. You will see across the top various ribbons, and there are two buttons here that you'll want to, instinctively you'll go to. The first is a Reports button, and that's where you'll select your OBQI, PBQI, and your OBQM reports from. Once having selected reports, you'll move to the left there on the top ribbon and select the Folders tab, and from there you'll be able to download or print your reports. So let's go further and look, start doing a little shopping here for our reports. You'll note here that there are several categories from the report category, and you select them from a drop-down menu, and essentially you have 5 options here. The first is Home Health Agency Provider Reports. Within that report, there are subcategories. OASIS C Home Health Agency Survey Reports. Again, additional subcategories once you click on that selection. OASIS C Quality Improvement Reports. You also have Utility Reports. And then the fifth is OASIS B1 OBQI OBQM Reports. And this is the previous version of OASIS, and CMS will retain that previous version for up to 15 years. So let's go in a little deeper to some of these subcategories that I spoke of. And the first we'll look at is the OASIS C Quality Improvement Reports. And some of the subcategories within there. We have 4 pages you'll see on the bottom. We're on page 1. And from the slide where I suggested to you the 5 essential, I've indicated the 5 essential with a red star. And we'll just go quickly through these pages. So the first report you'll want to select is the Agency Patient-Related Characteristics 3 report. The next is the Agency Patient-Related Characteristics Analysis Summary report. Selected that as an option rather than as an essential. You'll then want to go to page 2, where you'll find the Outcome Risk Adjusted 3 report and the Potentially Avoidable Event Risk Adjusted report. Moving on here, page 3, you will want to select Process Measures 3 report. And then we will go to the last. There's no selection here, but I just wanted to point out that there are additional options, and we'll talk about that later, and that is your tally reports, your patient characteristics, as well as your tally outcome reports. Moving into another subcategory, we mentioned home health agency provider reports, and I've selected here a report you'll want to run often. We'll talk about the frequency a little bit later, but that is your home health agency error by month by agency report. Other reports that I wanted to mention is the OASIS C Home Health Agency Survey reports. It's important to select OASIS C Home Health Agency Survey reports periodically, and certainly well before your anticipated survey by the state or an accrediting organization. This is the information that they will come into your agency with well-armed and well-informed about your patient population. Just a word about this selecting reports from this particular category. When you click on it, you will see that these reports are pre-selected for you and represent what the surveyors will download. In addition, the surveyors will pull your OASIS submission stats to determine compliance with your 30-day OASIS submission. All reports, whether it's the pre-survey, all reports typically default to 1 year. And this is important because it allows for a reasonable amount of data from which to draw conclusions about your patients, about your processes, and permits a more accurate view of patients and processes by virtue of a greater amount of data. With data that's less than 6 months, you run the risk of reacting to information that may not fully represent your patient population or your agency processes. A word about the Agency Patient-Related Characteristics Analysis Summary Report. This was the optional report that you could have selected and that we just selected a few slides ago. This is the screen that you'll come to, and this is a very exciting report. I love to run this periodically and sort of work backwards by first selecting an outcome measure. So, for example, improvement in transfers. This data that we'll download is in aggregate and looks at patient characteristics that are common to patients that achieved this outcome, as well as you'll see characteristics that are common to patients that did not achieve the outcome. So before we hit the highlights of report interpretation, it's important to emphasize how critical it is that staff are well-trained in completion of OASIS standardized data set. We know this is a moving target, especially as staff come in that may be new to home care, or even staff that have been on at your agency for a very long time. Everyone needs an update, and the industry is finding at least yearly to revisit the OASIS interpretation of those items. We certainly know CMS has charged agencies individually with ensuring the data is reliable and valid, and so will behoove you in using these reports to really ensure staff complete the OASIS data set accurately. Remember, your reports are only as good as the accuracy of your data. A few additional guidelines for data interpretation. You'll see on the 3-bar report, it includes current case mix factors, as well as agency prior that compares your current performance to how you would have performed 12 months ago if your case mix was similar to what it is today. The agency national compares your current performance to how you should perform based on case mix factors. So when I reference case mix factors, I'm referring to those items on the OASIS, so anything from age to health status items to ADL items, diagnosis, payment as well. So let's look a little bit deeper here. This is one of the first reports that we downloaded, and that's the patient-related characteristics reports. You'll note I've highlighted here the number of cases included in this report, as well as the year-long data period. This is an OBQI report, one type of report that was at the center of your performance improvement cycle. This report is a portrait of your patient population at the start or resumption of care. It also gives you a portrait of your patients at discharge. So this includes also information on length of stay, emergent care, and hospitalization. The patients in this mix are your Medicare and Medicaid patients. And looking at this report, it becomes useful as a tool to identify perhaps you may need to develop or modify policies, procedures, or protocols. Are your wound patients and type of wounds changing? Do you need additional guidance to staff on how to manage those wounds, especially if you're looking across reports and seeing perhaps not as much improvement as you'd like? It can be helpful to develop a care path or a specific disease management approach. And it can also help you on your review of patient educational materials to ensure that you're hitting the target, putting the information out there that is most needed by your patients. It also is very helpful in determining if there are any inconsistencies in what you're seeing, and perhaps identifying that you may need additional OASIS training. And it's also been helpful to determine maybe we need to hire up a specific discipline type or a specific nurse specialty type to address the increasing diabetic population that you're seeing. So one review tip when looking at reports here is to scan the report for significant differences between the national reference and your current. And that's indicated by either a star, and you'll see on the report several here, or a plus sign. And this indicates that the difference between your current case mix and the national is likely real and not just due to chance. So you'd want to focus on those areas to get a good sense of what's going on with your patient population. The next report is an OBQI report, risk-adjusted outcome report. And you can see here improvement in urinary incontinence. And this agency did quite well there, quite dramatically actually. Significant improvement is definitely obvious here. So what you'd want to do is look into that and celebrate the improvement, as well as attempt to replicate the interventions that were applied to these patients, resulting in such a good outcome. I would look to see, did we place a WOCN to address any incontinence issues? How did we improve that mobility? did we do specific bladder training? I also see improvement in urinary infections. So look to see what specific interventions have your clinicians documented, such as teaching to hand washing and hygiene, hydration. When you look at outcomes, ask how we intervene to move that patient towards a good outcome. And often that is going to take a little bit more investigation on patient-specific records to determine that. One tip here is your outcome report should be considered in conjunction with your process-based quality improvement reports. And as well, any agency-established care processes to ensure that they're being applied appropriately and as indicated. So here we have the process quality measure report. This is, as the name suggests, a PBQI report. This report can inform your practice when it's viewed along with the risk-adjusted outcomes report we just talked about. So, for example, was care timely? Were there prescribed parameters for measures to help in early recognition of a problem or a decline in the patient and corrective action taken at that point? Are we screening for depression, for example? And further to that, are we intervening appropriately? So always digging a little bit deeper. And that brings us to our potentially avoidable events report. This is an OBQM report that we mentioned in the QI cycle. This report gives you the incident rates for infrequently occurring untoward events. Potentially avoidable events can really serve as markers for potential problems in care. And I emphasize the word potential in that whether or not care was inadequate can only be determined on individual audit record review. So for this reason, it's extremely important to pull the potentially avoidable event patient listing, and a routine audit should really be conducted on all those patients listed to determine if anything could have been done to prevent an adverse outcome. I also have circled here the 4 records that were included in the emergent care for injury caused by fall. So it's important to look at the smaller numbers as well as the big numbers here. This is the report that I mentioned earlier as desirable and not essential. That's the patient characteristics by outcome. And on that screen, I selected improvement in toilet transfer. And you will see specifically in those call-out boxes the indication for negative number and the indication for a positive number. So a negative difference indicates that the case mix is higher for patients who did not achieve the outcome. The positive difference is the case mix is higher for patients who did achieve the outcome. So this report allows you to compare patients who achieved versus patients who did not achieve, in this example, improvement in toilet transfer. It's important here to start by looking at those indicators with the greatest difference. So if we stick with this slide, we look, for example, at the negative difference we see for around-the-clock caregiver availability in patients who did not achieve improvement in toilet transfers. This means around-the-clock caregiver availability was higher in this group. So the assumption may be that patients who do not achieve improvement in toilet transfers have around-the-clock caregiver availability. In the next example on the screen, where you see a positive difference in patients who achieved improvement in toilet transfers, we see IADL assistance was needed but not available. So the assumption is patients who improved in toilet transfers have a need for IADL assistance. However, assistance is not available. And so it goes down the report. Just a summary of how often you should be pulling your CASPER reports, and starting on the right-hand side of your screen, I had mentioned the error summary report by home health agency. This should be pulled monthly, and this really gives you an indication of your processes for OASIS submission. Quarterly, I would recommend pulling the Essential 4, Essential 5 reports if you're including the error summary report by home health agency that was prescribed on the slide in the beginning of this presentation. Certainly you want to turn to your CASPER reports with any major agency changes. So we see a turnover in staff, for example. You would want to be pulling your OBQI, OBQM, and PBQI reports to determine, how has that affected reporting? How has that affected accuracy? Certainly, if you're developing a new PI plan, you would want to pull the agency patient-related characteristics analysis summary report that we talked about. This will give you great information about the characteristics of those patients who achieved a particular outcome versus those that did not. Also consider using reports to identify patients for your discussions across providers in your transition of care meetings, your transition of care efforts to prevent rehospitalization. And then certainly we have many major industry changes coming down the pike yet again this year. Two in particular are your ICD-10 CM transitions from the ICD-9 that will occur October 1st. And then we have revisions to our data collection tool that will also come to play this year. A word about tally reports. These reports, contrary to the other reports that are in aggregate, the tally reports will give you patient-level data on all your measures. So their use is primarily to look more closely at the process of care on a particular patient, identify specific care processes that you can either reinforce or correct. Currently, I see the tally reports using to investigate and resolve any emergent care and acute care utilization issues. And they're also very important when you're targeting patients who have been in and out of the hospital or have high emergent care utilization. You will want to bring those specific patients to your discussion with your hospital SNF providers, for example. So this is an example of one type of tally report. There are two types. There's patient characteristics and there's outcome tally reports. So for example, man-moon, if you look down on the left-hand side of that report, you'll see this patient had a great deal of improvement in all activities of daily living. That's indicated by your legend in the sort of the top left-hand side of that report. So you'd want to look to see and look at other patients with similar diagnosis to identify characteristics that led to improvement or decline. How does man-moon differ from others with similar diagnosis, for example? And this report is your error summary report by home health agencies. I just wanted to spend just a small bit of time on this to remind you, please do pull this report. Agencies often forget to do that, and there may be a process, an easy process fix to enable you to comply with the 30-day submission. You see in this example for the error report 286, this one indicates, particular error report indicates that you have not submitted within the 30-day time frame 23.46% of your OASIS for that month. So you would want to look into that. When is the individual in your organization submitting? Are they submitting weekly, or do they wait till the end of the month to submit? That may be problematic. Now, I just wanted to mention, on this report, you will see the error number listed on the left. The particular data dictionary related to all these items can be downloaded from your CMS website. It is important to really, like I said, pull this. The state does look at this, and there are specific percentages that will concern them. For the 286, anything above 20% may trigger more of an investigation. There are also many tools out there to indicate what sort of measures, potentially avoidable events at 15% or above. So do look into that. These are particular errors will allow you to submit. There are many different types of errors. There are fatal errors that will kick back the OASIS. There are also just warnings, so warning the provider that you may have a process issue here. So at this point, we've just touched the surface of managing by data. We know that OASIS reports provide critical information needed to inform your agency about vital processes and care interventions. We also know that in this provider climate, agency-level knowledge can be lost as work functions are consolidated or as staff holding QI knowledge leave the agency. So it's important to really have a good understanding not only about access but interpretation. In order to further assist home health agencies in this regard, we are publishing a reference guide that covers accessing CASPER reports, report interpretation, and we'll also give you case examples of how agencies have used the information to improve care processes. The guide will be out mid-April, so please look for that on our website, or contact me directly if you would like additional information about the guide or assistance with your reports. At this point, Kathy is going to talk to you about managing by data to inform your compliance program. Thank you.
Okay. Thank you very much, Rita. It's a pleasure to have everyone listening in today on this call. And I'd like to begin by raising the question of why does the ability to ensure that you have achieved full regulatory compliance really matter? And I think that the critical issue is that if you are not in full compliance, it will be nearly impossible for you to achieve any of your quality management or process management outcomes. You will have great difficulty in achieving improvement and meeting your goals if you are not remaining in compliance. There are 4 critical things that you will accomplish when you have achieved regulatory compliance. You will have successful Medicare certification survey outcomes. You will have successful accreditation survey outcomes. You will achieve maximal patient safety, and you will see the impact in each and every one of those reports that Rita has shown you, and particularly at the patient level in the tally report. You will be able to see how compliance is in making it possible for you to maximize and achieve optimum patient outcome. So if that's our goal, what is it that we at Qualidyne can do to help you? What we have focused on is trying to make this process as easy and effective as we can for you. And so we created an internet-based online piece of software that we call Qualiance, because This is the marriage between home health quality and compliance. It's a solution to addressing some of the tasks that we are mandated to do while providing you with a great deal of information that can truly meet your needs. The Qualiance tool is focused upon meeting a mandated function, quarterly clinical record review. It's clearly required and outlined in the CFR from Medicare. The annual report requirements, program evaluation, these are clearly listed as functions that we need to do that Qualiance can certainly help you with. The key areas in the Qualiance tool have been set up so that they link back to the most frequent areas cited by surveyors of every kind. The primary areas of citation seem to be in the rights and responsibilities, physician's orders, and following those, keeping your visit frequency and your treatments within those orders, assessment and reassessment of the patient as the plan of care changes and as the patient's condition changes, medication reconciliation. We will never achieve successful care transitions if we are not able to make sure that successful, ongoing medication reconciliation and medication compliance and coordination are effective. And finally, care coordination amongst all the members of the interdisciplinary care team and effective supervision of those ancillary supportive providers has been frequently seen as a citation. With Qualiance, because we began providing quality management assistance and with other providers, Qualidigm has a data pool that we have used to test the Qualiance tool. And what we have seen is that its reliability is averaging approximately 95% in terms of its ability to predict where your compliance problems are. And using the Qualiance tool, you are now going to be able to create a targeted performance improvement plan that focuses directly on those problem areas. The Qualiance tool does allow you to do 3 types of audits. You can audit your home health data, you can audit your hospice records, and you can do a focused audit. A focused audit is particularly critical because in this way you can tie back, yet again, to the various CASPER reports, and you can respond to those changes as they occur within your agency. Staff turnover is an excellent reason for focusing on the CASPER reports to see if that has affected your ability to provide quality care. It also is going to affect your compliance. So when you've gotten that new staff nurse on board and you think that you've been training her effectively and her mentor's been teaching her effectively, if you use a tool like Qualiance or some of the other similar tools available to you, if you use it as a focused audit, this is going to tell you whether Susie, my new nurse, has actually internalized and is using all of the things that you have taught her about how to create and manage and implement a plan of care and to do it with reliability and compliance. So our reliability is consistently at 90% or greater and has been averaging close to 95. If you were to look directly at our Qualiance tool, when you go to the web and you enter www.qualiancehomehealth.org, this is going to take you to our website, and I'm going to show you what Qualiance looks like. This is the website that it's going to bring you to. It says Qualiance. You would be given a username, usually your own email, and we would send you a unique password to get into your particular data set. Once you've gotten in there, you put those in and you sign in, this is the first screen. I want to reassure everyone that if you choose to use this particular internet tool, your HIPAA data is 100% protected. As of Medicare Contractor QIO, just as WVMI is, we have certain criteria we must meet in terms of protecting patient-protected data. This system meets all of the CMS requirements for protecting HIPAA confidentiality and protecting your PHI. When you enter a patient, you're going to be putting in that patient's medical record number, which is something unique to your system. Your naming convention was something you created. It's also, along with the patient's date of birth, the only thing that identifies this person. Now, I've used this poor ABC123 many times in demonstration. And so today, I'm going to select this particular existing record so that I can show you what it looks like if you were working with this system. In CARE program, as I said, you would have the choice of a home health audit, a hospice audit, or a focused review. For ease of demonstration, I'm going to use a home health audit. Had you selected focused audit, a screen would have appeared over here in the open space on the right, allowing you to select from specific questions in each of the other screens. So that you could, for instance, when we go to the medications, you could be doing an audit of 10 records to determine the nurses involved, their compliance with how they were managing medications, documenting administration or pre-pour, documenting interaction and contraindication, etc. This data that's entered in on the CARE program screen allows you to do an audit of a specific time frame. You'll be able to look at specific diagnoses. You enter start of care, discharge status if it's a discharged record, who the reviewer is, and when it was done. When you've completed entering data in any screen, it's always recommended that you save at the bottom of every screen. Notice the green bar. The green bar tells me that since the last time I entered this file, I'm 67% completed with my audit. That allows me to simply save and exit if I'm interrupted at the end of my workday or my patient's, and then can come back to this at a later date without ever having lost my data. As I said, each of these screens represents a focal area that has been of frequent concern in citations at both the standard and the condition level. Rights and responsibilities concerns how we have addressed the patient's need to be fully informed. I want to point out to you, since the ABN has caused so much stress for many of us, our tool called the Data Dictionary. Any question within the Qualiance tool, the most critical element in getting reliable data is that you and I and everyone who answers a question is answering it in the same context. So if I hover over a question and click on it, the data dictionary information is going to appear. Please note, this is not requiring you to hover over it and hold your mouse perfectly still. You are able to take your time, read the definition, understand how it wants the question to be answered. When you are sure you are clear, you simply click OK, and now you're back on the screen, able to now answer the question so that we are all answering it with the same interpretation. Physician's Plan of Care looks at those pieces of the 485 or interim orders. It is asking you to be sure that particularly those areas frequently cited, that you have diagnoses to match an assessment, medications, and the history, and the active treatment plan. Our surveyors that we deal with most frequently in the New England area often tell us their feeling is the physician's plan of care, the nurse's plan of care, and the assessments must all tell a coherent, cohesive story. They must paint a picture of where the patient came from, where they are on admission, how they progressed, what the plan is, and what the goal is. And if you look at each of these questions as you are reviewing a file, you are going to be not only in compliance with all the G tags, all of your individual state licensing tags, all the accreditation standards, but you will also be maximizing the quality and safety of your plan. So this section deals with all the physician orders. This one looks at your nurse's care plan and what exactly is involved in it. I want to draw your attention here to the fact that there are two color bars on this screen. This is the first of the accordion files. You will notice here that in this case we have said that this patient was not a hospice patient. Because it was not a hospice patient, those items that relate primarily to hospice only, pastoral, bereavement, and volunteer, the NA in this screen is much lighter. It's been grayed out. Our goal was to eliminate human error wherever possible. So you will see as we move forward, questions pertaining to occupational therapy are gray. Those for MSW and physical therapy are available for me to answer. You are selecting the disciplines that were participating in the plan of care. By clicking on the lower color bar, you are now able to address those components of the plan of care content that have most often gotten us into mischief. Notice that there's a comment box at the bottom of every screen. This comment box enables you to put reminders here, items that you particularly want to remember about why you answered a question the way you did, or that you want to remember for the purpose of staff education, individual or group. This enables you, when we go to the reports, to know exactly what you were referring to and what you wanted to emphasize when you began to do your teaching based on the results of your audit. Assessments deals with the contents of the clinical notes provided by the skilled nurse. Medications, as I said, is looking at medication reconciliation, the documentation on the profile, did you review for contraindications, have you documented correctly your administration and your pre-fill, including a source document. This is such a critical issue, particularly with accrediting bodies. If you remember, I mentioned to you before, these screens, once you get into ancillary and therapy and hospice, are affected by the skip patterns, affected by the answers you gave us in earlier areas. This patient did have home health aid services, so here we are addressing all of the pieces that are focal points for the home health aid service. Supervision, orientation, following and documenting against the care plan for the aid. With an LPN, we remember that this individual, this level of caregiver, requires orientation and supervision, albeit at a different frequency, but they still must be supervised, and that the RN is still responsible for coordinating and directing care. For those who do provide hospice services, and for those who provide highly technical shift nursing cases, here we have a screen dedicated to the shift nurse who provides service under continuous care for hospice or for the medically fragile complex patient. Again, we are looking at similar parameters because these are supportive disciplines. Has there been a clearly defined plan of care? Was that nurse oriented? Did the primary nurse supervise the shift nurse according to your policy or at least monthly? Have we had good communication between the shift nurse and the primary and the clinical supervisor? Documentation is adequate, and again, from the hospice requirements, professional management of the plan of care and care coordination. Remember, as I said before, we had indicated this patient did not have occupational therapy. Therefore, all of these questions have been grayed out. That applied to speech, which was not included, but medical social work and physical therapy are available and will need to be answered in order for you to reach 100% completion. An area to note here is Visit 1319, your frequent summaries, and very much an area of concern for CMS and for the accrediting bodies. Safe care requires that the homemaker home health aide be properly oriented and supervised to any therapy component of the aid plan of care, to complex transfers, and the use of adaptive equipment. This is critical to maintaining patient safety and having successful outcomes. This is an open record, not discharged. So the NAs being grayed in here make sure that human error does not put data points into these fields. Had this been a hospice record, all of those components that are similar to the pieces in home health would be here with the detail elements that apply specifically to the hospice program, such as hospice election, the advanced directives or some type of an equivalent, the covered and non-covered medications, the specific day 180 face-to-face that applies to hospice, the physician CTI and the attestation regarding the ongoing need for hospice services. Care coordination reflects those cases not only in the IDT, but where you have a patient who is in an inpatient facility, do we have professional management and inpatient assessment? Complementary services is pastoral, bereavement, and volunteer. And this area of assessments and interventions, remember, we have assessments in the regular nurse's notes, but in hospice, we were focusing on those areas that NHPCO had identified as frequently being of concern. Do we have ongoing assessment and evidence of benefit on eligibility continuing? Did we have adequate bowel symptom management, terminal symptoms controlled for comfort, pain management, and the patient and or the primary caregiver being fully prepared as best as we can for the dying process will give the hospice provider a much better outcome when we are asking in satisfaction surveys if they felt ready and did they feel comfortable when the dying occurred. Discharge services applies to hospice, and as you can see, the appropriate areas were touched on here. So when we have completed entering records, obviously we'd all like to know what our data looks like. So what we have done is we have provided the agencies with some very, very exciting reporting capability. If you're an agency with multiple branches, you will be interested to know that you are able to compare branches one against another. This particular demonstration agency had 3 branches, and currently their Wethersfield office is 88% compliant. Their Rocky Hill office is doing a little better at 94%, but their Middletown office is only 75% compliant. I'm thinking I would not want to be working in Middletown when the surveyors arrive. By clicking on one of those particular branch towers, you are able to look at now the compliance dashboard for that agency. Note the bright colors. We chose these colors because it's important to draw your attention to the red zone. As you look at each of the sections that correlates with the areas you entered data in, you will see each of the questions has been scored in compliance as being green or full compliance, 95 to 100%, yellow, 85 to 90%, yellow meaning that it bears watching, red meaning you scored less than 85%. This means you are at high risk for a condition level deficiency. So let's take a look at one of these red zones. In this case, let's look at the face-to-face. When you clicked on that particular bar, you are now able to see the details. This tells me that we looked at 14 records and checked them for that question. We now know what files, what nurse, how they succeeded at that question, and what the comments were that I wanted to remind myself of. This is a very important piece because it allows you to now go back and say to Mary, you seem to be forgetting to do this. Or to Nancy, you seem to be forgetting to do this. And it's going to help you to determine if the problem is at the branch level or is it at a specific nurse's level. In this case, it appears that Nurse Mary Mercer does not seem to be able to get her face-to-face documentation in. If you look here at this drop-down, you can export this report into any one of these formats and now save and print the file for your future use. The little blue button is going to take me right back to where I was, so that now I can select a different question to look at other reports. These reports are critical to being able to use this data as it was intended to be used. So if we return now and we think about how would we use this for compliance improvement, any area at or below 85% requires a focused audit. You can now go back into Qualiance, pull Mary Mercer's charts, do 10 audits of a focused audit on those questions that she scored very poorly on. Now you can do a focused remediation action plan for the clinician, for a branch, or a diagnostic group. You can target remediation directly to red areas. Your focused audit will ensure the success of your remediation plans. By focusing on the care plan and the assessment, as I said, you're going to know, did you have all the right components, measurable parameters? Did you implement the plans? And did you document the patient's response to their treatment? If you've had a shortage of qualified clinicians, did your CASPER reports tell you that you needed to do a focused audit to improve on a specific outcome, and now you need to know, is it that branch? Is it that team? Is it that nurse? By doing the focused audits in Qualiance, you now are able to identify where your problem is, to do a focused audit to get the data, target your education plans, and then make sure that you have targeted improvement for teams and branches. If you have any further questions about Qualiance, we would be happy to discuss it with you. And anyone who is interested can go to the web link that I gave you, www.qualiancehh.org, and you can try a free trial at absolutely no cost or obligation on your part. At this point, Rita and I thank you for allowing us to speak with you and share some of our thoughts on using CASPER to its most effectiveness and giving us a chance to share Qualiance, which is our newest and most exciting product. At this point, I'm going to turn the microphone back over to Ms. Siekevich so that she can share some of the HHQI resources with you.
Thanks, Kathy, and also Rita. We do have a few Q&As that have come in through our Q&A box. If anyone else has Q&As, please go ahead and post those. We'll handle as many as we can. The first comes for Rita, and it's from Karen. What do you do if these reports are dated 2010 or before? There are very few that is available for current time since we just opened in 2010.
Thank you, Karen. Yes, if you're not seeing any data from 2010, I would suggest that you know when your last data submission occurred. And you can do that by going to the home health provider reports, specifically your error summary report by home health agency. And you'll be able to see, as we discussed, your error rate with submission. If you're certain that you've submitted your OASIS data in a timely fashion and consistently, you may want to then contact the QTSO help desk for further assistance.
Thanks, Rita. Our next question comes from Mary Ann. Is there a benchmark for error reports besides the number 286? And if so, what are the other numbers that are most concerned for monitoring?
Yes, there actually are, and you can actually find some of those benchmarks on your surveyor reports or the surveyor tools that are used when they come out to survey your agency. And I can't give you the site right now because I'm not familiar with the site to download, but you would want to look at specifically, they're typically either 15% or 20%.
Thanks again, Rita. If you have any additional questions, do please send them in. We do have a couple for Kathy, but I do want to throw in just another really good point here. It's first, in this presentation, that was a lot of information that Rita covered because it's down and dirty, kind of doing a quick overview. The slide handouts are posted on the up page of the HHQI. And it's probably more meaningful if you download your own CASPER reports and possibly re-listen to this presentation or look at the slides, because the data in this presentation is fictitious and it's not going to be as meaningful as your own data and your understanding your own organization. But I probably would utilize the resources and the handouts to be able to learn how to access the data, also be able to look at your data. And then we're absolutely welcome both at HHQI as well as Qualiance to very willing to help you understand your data information. Another really good point that I think Rita has made, it's essential for you to create processes and who's responsible for collecting the data that she talked about. You know, CASPER data, as well as your Home Health Compare, and we'll talk about HHQI here in a minute. But you need to have backups because we do have changes in staff repetitively. So you need to have a standardized process as well as responsibilities and a timetable as to when those should occur so that you don't find yourself a year and had not downloaded any information. Okay, let's see, Kathy, we have a couple questions for you. First from Diane, so does this data have to be manually entered?
Thank you, Misty. Yes, Diane, it does at this time. We are in discussion with several of the electronic record providers to see if they can create interfaces for agencies with their electronic record systems. At this point in time, however, you do still have to enter your audit data directly into Qualiance as you go through. However, Qualiance reports have been acceptable to all of the surveyors, be they your state surveyors or your accreditation and certification surveyors from an accrediting body. So that should work. And we have found that the majority of agencies, unfortunately, are still using Excel spreadsheets, paper tools, and one of the advantages to anything that you can automate is that you are saving time. All of our schedules are so full that even though you do have to do data entry, it's still faster than doing it manually on paper.
Great. We have a question, actually it's twofold, from Rose. How many users can an agency have to do the data entry, and how much does this product cost?
In regards to the number of users, you would be given one user ID, usually a specific email address. How you use that internally is really handled by the agency so that this ID, being perhaps your quality manager or clinical supervisor's email, nothing else goes to that person's email except a password change or a password update. The password itself could be saved and it would stay automatically, or it would have to be shared if you chose to have multiple users on one ID. In terms of cost, if you are an agency with one location, and you do not have any need to separate data by teams, then your cost would be $200 a month. And our system, when you set yourself up in the system in Qualiance, you can do this as a PayPal monthly automatic system. If you have multiple branches, as in the demonstration I showed you, a database agency that had 3 branches, that agency pays $600 a month because in order to maintain the ability to have multiple branches compared, you need to have 3 data sets. If you have multiple branches and you choose to have a separate data set for each, we would give the administrator one user ID and password that would allow them access to the comparison between branches, and then each branch person would have their own user ID and password that gives them access only to their branch's data. That allows the administrator and anyone he or she chooses to share with the branch comparison data, but at the branch level, the individual entering the data for that branch would be the only one with access to that particular data.
Okay, thank you, Kathy. That's all of our questions that we have right now. If you have anything else, please make sure that you do send this into the Q&A. We're going to cover some HHQI slides right now. But again, I think Kathy's points to making sure you have a standardized process, identifying those key areas that are problematic for agencies and making sure that you're addressing them on a regular basis so that they also don't get out of hand. Both topics are very relevant with day-to-day functions, not only just for surveys, but also for patient safety and outcomes. Now we're going to look at a little bit, just quickly, on some HHQI resources related to data. We have the agency reports that all Medicare certified home health agencies that are reporting data are able to obtain. We have acute care hospitalization data, multiple types of data related to that topic, oral medications, and influenza and pneumococcal immunizations. If you've not downloaded those, they are uploaded monthly with your current OASIS data that is being entered. You're getting a much more current than CASPER reporting and some different reports than you can get in CASPER. These reports are very important. We're talking about primarily CASPER and a little bit about HHQI today, but it is essential that you look at all of your data. The data can't necessarily be compared one to the other, but you really need to look at your CASPER data, and I think Rita talked about some of the really specifics of why, and your home health compare so that you can see what's being publicly reported. That data is very different and the time periods are different, but all very relevant to your QI planning as well as your patient care, as well as the HHQI. You really do need to look at all three. If you have trouble and don't understand the HHQI data or any of your other data, we're very happy to help you out. You can contact us at hhqi@wvmi.org or anywhere on our website. There is a contact us and we will get back to you. We do caution, never ever email your reports to us or even to Qualiance because you need to have a secured arrangement. Remember, this is patient level data or at least agency related data that has to be kept secure. With the agency reports, the ACH, the oral meds and influenza and pneumococcal, all of that information is on how to access it and to sign up to be able to get it. It's on the site, and we have given you a link. If you could turn the next slide, Kathy. What's new with data with HHQI in the last, I think about 9 months now, is the cardiovascular risk reports. These are new reports. They are located actually right underneath of your ACH reports if you haven't gotten those, well actually under your immunization reports if you haven't gotten those. Because OASIS does not have a lot of cardiovascular topics built into OASIS C, we have utilized what is there to create like a risk report, your at-risk population and your regular population. All home health agencies that are reporting CMS certified can have access to this report. There's no additional data required. It's looking at some of the information that we know through research puts your patient populations at risk. But what is different is the HHQI Cardiovascular Data Registry. This is brand new. It is a pilot that we have been doing for CMS. Current focus is looking on aspirin as appropriate or any other antithrombotics for ischemic vascular diseases, and also prevention, screening, and controlling hypertension. That's 2 of the ABCSs that our cardiovascular health education has been about. With these home health CDR reports, these are for agencies that are abstracting. We're talking about accessing, we are pulling down from your OASIS as much that we can for each patient that's going to be in what you're abstracting, and you may be asked from a minimum of 2 additional questions up to 4 questions that really will getting that additional information through chart review. You are able to pull into this information and give you much more robust reports about the cardiovascular health and your outcome measurement related to aspirin therapy, as well as hypertension prevention, screening, and control. Lots more available resources are located on this link on the slide, and if you'll turn the next slide. So that's our data. If you really have never done any HHQI downloading of your data, please follow the instructions or contact us. We'll be very happy to help you. And I'd like to reiterate again, it's really essential you do your CASPER, your Home Health Compare, as well as looking at Home Health Compare. You will get different pieces of information to help you in your quality improvement outcomes. We do want to tell you about an evidence-based health coaching webinar. Melinda Hoffman is presented a wonderful presentation on defining health coaching, how it works, and why traditional methods have fallen short. It is already recorded and posted on the link that is provided in your handouts. Next slide. Our next up networking call is February the 26th from 3 to 4 p.m. Eastern Time. Diane McComb will be with us, and she's a subject matter expert from the Disparities National Coordinating Center, and she is going to be talking about health disparities among people with disabilities. We'll be looking at the federal criteria for determining disability, profiles of people with disabilities. We'll talk about the dual eligible populations, and health concerns and solutions for people with disabilities. Next slide. And I think that's time for us to thank you. We thank you for the little extended time because this was a significant topic to talk about today. I want to personally thank both Rita and Kathy for their time and expertise today to talk about 2 essential topics for home health agencies. And do take time to review the handouts again. Compare them to your data. Re-listen or ask other people to listen to this presentation so that you have as many people knowledgeable about getting CASPER reports and taking a look at that. And again, there is contact information for both presenters today as well as HHQI. We're all very happy to help you in your endeavors for improving quality of care. So again, thank you, and we hope to see you soon.